Hi everyone, Peter Nash here at ACR Washington 2024, reporting for Room Now. Today we're going to discuss what we saw at this meeting on JAK inhibitors. And anyone who thinks they're going away really needs to take another look, because there was over 50 abstracts on JAK inhibitors and they covered all kinds of different aspects of therapy. So one of the first things that we'll talk about is JAKs and herpes zoster vaccination, which is an important issue for most of our patients now. There are a couple of abstracts on that, many abstracts on safety that we'll delve into, lots of abstracts on novel indications for the use of JAKs, as well as novel JAKs themselves that we can discuss. Abstracts on combination therapy, JAKs and other DMARDs. Things about the JAK signature, the JAK signaling, trying to understand a little bit more how JAKs work, proteomics, and even combination therapy, as we've discussed. So if we tackle some of those, and to summarize them, they showed in a Spanish study, and it was followed up by Jeff Curtis, that being on a JAK, particularly long-term JAKs, blunts your response to zoster vaccination. And I'm talking about the inactive Shingrix recombinant vaccine. So the response is blunted, you have lower antibody levels, you have suppressed CD4 and CD8 cells, you don't get the same response. So it makes sense to vaccinate people before you put them on their JAK inhibitor if you can, and it's something really to think about early on in the patient's journey, because Jeffrey Curtis showed that if you stop for 14 days, it makes absolutely no difference to the blunted response. So to say we're just going to interrupt therapy for a couple of weeks, the response is still blunted. It's probably adequate, but not as good. So there are lots of other issues that we can discuss. Safety, of course, was a major area where we had many abstracts. Why? Because oral surveillance just about devastated the JAK market. There were abstracts looking at the effect it had on prescribing, and mostly, initially prescriptions dropped off, only to pick back up again over time. But it did tend to push the JAKs into the third line of therapy rather than the first line, unless there was a good individual patient reason to go first line. There were meta-analyses of the trials that were undertaken where they tried to compare JAKs with TNFs, and they looked at all the usual stuff, but this particular trial looked at malignancy but excluding non-melanoma skin cancer, which we know the JAKs have a signal. So they meta-analysed 198 studies, including 123,000 patients, 133,000 patient years of exposure, and they came up with a background malignancy rate in these populations of RA, PSO, PSA, IBD, AS of about 7.7 per thousand patient years of exposure. And the TNFs, bottom line, showed that there was significantly less risk of malignancy with the TNFs compared to the JAKs, and even the TNFs compared to placebo. And there wasn't much difference between the JAKs and placebo. So the reasoning for that is a little hard to understand. However, there's two issues. One, that TNFs might well be protective, and that might have explained the difference that popped up in oral surveillance. And the JAKs like to suppress NK cells, and NK cells are involved in viral and neoplastic surveillance. Personally, I don't believe the lung cancer story from oral surveillance. If you have a good hard look at the actual numbers, you'll find out of 1,400 in each arm, the JAK side had 40 more chronic smokers, the TNF side had 40 less ever smokers, and you only had to move 7 cases from one side to the other, and there was no difference between the two arms. And if you look further at other malignancies, in oral surveillance, melanoma 5-1 on the JAK side, on the TNF side compared to the JAK, and prostate cancer 3-1 on the TNF side compared to the JAK. So I think it was a quirk of the study, but there's definitely a non-melanoma skin cancer signal. Now, there have been a number of other papers, as we'll briefly mention, combination studies, a very small case series. I think combinations are here to stay for the very difficult to treat PSA patient, where you combine one of the safer drugs, the 17s and the 23s, with either a TNF or a JAK. One group combined JAK plus TNF, and lo and behold, they got lots of infection, and I wouldn't recommend that as a choice. So the combo studies are being done, and then new indications like dermatomyositis, there's a study that's being promoted, and uveitis, JAKs being used as a treatment, and ILD, where the JAKs have been shown to stabilise and prevent progression, but complicated by chest infections in one case of TB. So lots of different aspects of JAK inhibition. Here at Washington Room Now 2024, we'll discuss the novel JAKs and the novel indications another time. Peter Nash signing off.